everyone. Today I'm going to talk about essentials of management of epilepsy in pregnancy. If we look at the most recent Embrace report from the UK of 2024, neurological conditions such as epilepsy and stroke remains one of the most important factor or cause of maternal mortality. And therefore, it's important to speak about this topic and to create awareness among the healthcare workers in order to manage these patients in a holistic approach and to reduce the risk of maternal death secondary to neurological cause. So we're going to first speak about preconception care, followed by antenatal management, intrapartum care, postpartum consideration, and lastly, about new onset seizure in pregnancy. So let's go through the very first clinical vignette. I would like to share a case who came to my clinic for preconception care. She's a 25-year-old lady, para 1, and her last childbirth was 3 years ago. She's got underlying generalized epilepsy, and it was diagnosed at the age of 16-year-old. She's now on carbamazepine 200 milligram twice a day and valproate 400 milligram twice a day. She had a history of status epilepticus and was cared for in the ICU, and she was ventilated back then. At the moment, her seizure frequency is about 3 to 4 times per year. However, she's not on contraception, mainly because she thought she was told that valproate will act as contraception, but the truth is she was told not to get pregnant when she's on valproate. Her other comorbid include BMI 35, and when I explore further, she's actually keen for pregnancy. So what's important in preconception care? We must not forget to explore the fertility desire and contraception the patient is taking when we are seeing a patient in preconception clinic. It is important to establish the diagnosis of epilepsy and not just believe that this patient indeed has epilepsy. We need to review the need for any anti-seizure medication, and if that is necessary, what are the choices of anti-seizure medication best for this patient? And obviously not to forget folic acid supplementation once this patient is deemed safe to proceed or embark in pregnancy. So more than 60% of pregnancies are actually unplanned. And when we talk about contraception, it's important to remember some of the anti-seizure medications are actually enzyme inducers, and they reduce the efficacy of hormonal contraception, especially combined hormonal contraception. Strong inducers such as carbamazepine, phenobarbital, phenytoin are significantly reduces the efficacy of combined hormonal contraception and hence should not be used at the same time. Whereas non-inducers such as clonazepam, lacosamide, levetiracetam, and valproate can be safely used together with combined hormonal contraception as long as we can assure their compliance to both the oral combined hormonal contraception and their anti-seizure medications. So in patients who are taking strong enzyme inducer, perhaps it's wise and it's strongly recommended for them to use intrauterine device, more of the copper intrauterine device as it is non-hormonal. A patient can also opt for depo-methoxyprogesterone acetate because it's been shown to reduce frequency of seizure attack, breakthrough seizure. On the other hand, for patients who are taking non-enzyme inducer, they can opt for any long-acting reversible contraception. What's worth to note here as well is oral combined or hormonal contraception also increases metabolism of lamotrigine. So it's not just the enzyme inducer can reduce efficacy of hormonal contraception, but hormonal contraception can also increase metabolism and clearance of lamotrigine. As such, this would reduce the plasma level of lamotrigine by at least 50%. And for patients who are using enzyme inducers as their seizure medication. When it comes to emergency contraception, it is important to increase the dose of levonorgestrel, in fact, to double it up to have effective emergency contraception. Next, we need to revise the necessity for the use of anti-seizure medication in this patient. So some of these patients are actually seizure-free for like decades or two, and they are still on anti-seizure medication. We are not sure whether they really need it. Hence, it's important to establish the diagnosis, to differentiate, more importantly, psychogenic non-epileptic seizure from epilepsy per se, to understand what is the most appropriate choice and dosage of anti-seizure medication for this patient, and whether there's any possibility or any potential to withdraw anti-seizure medication in this patient. And in some of the patients with refractory symptoms, we may also discuss about resective and ablative surgical treatment, more so for patients with localized epilepsy and those with temporal lobe involvement. So it's important to discuss with the patients what are the appropriate choices of anti-seizure medication before we identify the best option for patient. It is crucial to know some of this important history, such as prior medication failure, epilepsy syndrome, whether it is generalized or it is a localized ones, what are the seizure severity and the adverse effect of this medication on patient, and also underlying comorbidities as well, as this may limit their option of anti-seizure medication. So it's we are not talking about anti-seizure medication without talking about major congenital malformation among the offsprings of patients who are taking anti-seizure medication. So this graph comes from the Europe study and the some of the other epilepsy and pregnancy registry. And it is very obvious from here that patients who are taking valproate, their offspring has a higher risk of major congenital malformation compared to those taking lamotrigine or levetiracetam. And offsprings exposed to phenytoin and topiramate may also be at significant increased risk of congenital malformation. And congenital malformation is also dose dependent. The risk of malformation is also dose dependent. And we can see from this graph, obviously patients at higher dose of valproate has a very much significantly elevated risk of congenital malformation compared to those who are using a much lower dose. You can see that patients who are on lamotrigine are at the lowest risk of congenital malformation. So let's talk about valproate. There is an increased risk of infant congenital malformation up to about 10%, and this certainly is dose related because patients who takes much higher valproate dose, such as 3,000 milligram per day, are at a significant risk of about 60%, whereby their offspring may develop congenital malformation. Unfortunately, there is no safe threshold dose. Patients taking even up to 1,000 milligram per day are already at significant increased risk of congenital malformation. And when we speak about congenital malformation, we meant neural tube defect, cardiac defect, orofacial clefts, and also deformity with the skull, limbs, and digits, and so on. But this risk extend even beyond first trimester. So we traditionally say patients who have passed first trimester, the risk of malformation is extremely low. So that is true for structural malformation. Unfortunately, for valproate, the risk goes beyond first trimester because there's also increased risk of neurodevelopmental disorder, including autism spectrum disorder, cognitive impairment, motor and behavioral problem as well. So there were studies which showed there were retrospective study which showed that valproate exposed children actually require additional assistance and additional support when it comes to their school performance. So this is a studies looking into the odd ratio and absolute risk of congenital malformation in offsprings exposed to sodium valproate. And of course, it's well versed that the risk of neural tube defect is highest. So spina bifida, the odd ratio is about 12.7. But nonetheless, there is also higher risk of congenital heart deformity, facial cleft, and skeletal problems such as craniosynostosis. And this is a large study conducted recently looking at the association between the prenatal valproate exposure and performance in school. And if you look at the graph, offspring exposed to any form of AED are already at the higher risk of having problem at school. And very obvious offsprings exposed to valproate are significantly, they do significantly poorer in school in terms of both language and mathematics. So it's not just about maternal exposure. Recently, we've spoken and there are talks about paternal exposure as well to valproate. And because there is higher risk of impaired male fertility and neurodevelopmental impairment in the offspring to the fathers who are exposed to valproate. So the UK Medicines and Healthcare Product Regulatory Agency now has advised to avoid valproate, to avoid starting valproate in any male patients below 55, that means those who are at chance or those who are still within the age of having a family or with a fertility desire. So we also need to talk about folic acid supplementation. So we know that neurotube defect is mainly because of folate deficiency. Therefore, patients who are taking anti-seizure medications are also encouraged to take folate supplementation during their preconception period. For general population, 0.4 milligram is adequate, but what about for patients who are taking anti-seizure medication? What is the dose that is adequate for them? So general populations is 0.4 milligram. Patients with a previous pregnancy, personal or a partner with the history of neurotube defect should be taking 4 milligram to reduce that risk. All other women who are taking any form of anti-seizure medication should be on about 0.8 to 1 milligram, whereas those who are taking specifically carbamazepine and valproate should be on 2 to 4 milligram daily of folic acid supplementation. And folic acid supplementation has been proven to improve neurocognitive and behavioral development in offspring. However, too high dose of folic acid may contribute to pediatric cancer and lower psychomotor score in the offspring. Therefore, it's important to supplement with folic acid, but beware of the dose that they are taking. Next, I'm going to bring you to the management of epilepsy in pregnancy. And obviously, we're going to speak about antepartum, intrapartum, and postpartum consideration. So let me share my second clinical case. This is Madam JD. She's 35, primary gravida at 13 weeks gestation. She has got generalized epilepsy and on lamotrigine 100 milligram twice a day. She was seizure-free 3 months prior to conception, and she was switched from valproate to lamotrigine because of that. However, soon after switching of medication, she conceived. And she noticed her seizure control deteriorated since she found herself to be pregnant. She's now really anxious about the risks of her condition and medication to her baby. So what are the implications of epilepsy on pregnancy? Studies have shown, in fact, this is a systematic review and meta-analysis that show that patients with epilepsy are at a much higher risk of poorer perinatal outcome, and this include miscarriage, stillbirth, preterm birth, maternal death, NICU admission, and neonatal or infantile death. This is another study that looked into the risk of perinatal and maternal mortality among patients with epilepsy, and it is not surprising that the composite severe maternal morbidity and mortality is very much increased in patients with epilepsy. The risk of maternal death is higher. The risk of perinatal mortality and neonatal morbidity is also significantly higher. So the UREP study or the UREP observation look into the seizure control and treatment changes in pregnancy, and they've concluded that actually, although we are extremely anxious and worried about patients with epilepsy in pregnancy, more than half of them actually remain seizure-free. And generalized tonic-clonic seizure only occurred in about 10 to 15% of our patients. Women with idiopathic generalized epilepsies are more likely to remain seizure-free than those with localized related epilepsy. The anti-seizure medication dose is increased in epilepsy in about a quarter of our patients. Most of the time, this happens in a second trimester. Seizures are more likely to occur in first trimester. Only 21 cases actually reported with status epilepticus, and from the UREP registry, there was no maternal mortality and there was one stillbirth. This is the other registry looking at the management of epilepsy in pregnancy, and they too concurred that most of patients remain seizure-free in pregnancy, the pre-pregnancy seizure control is the most important predictor of seizure control in pregnancy, and most patients have breakthrough seizure due to non-adherence to anti-seizure medication. So let's talk about breakthrough seizure. Breakthrough seizure is mainly most of the time due to reduced serum drug level, and this happens due to non-adherence to medications. In patients who have severe nausea and vomiting or even hyperemesis gravidarum, there is a significant pharmacokinetic alterations during pregnancy, and this includes altered absorption, there is increased volume of distribution, elevated renal excretion, and increased liver enzyme activity, and all these reduce the serum plasma level of the drug. And increased seizure risk happens when there is a drop in blood levels above 60%. It's 2/3 of the original level, and this most often happened in the second trimester. So this is a very nice diagram depicting the relationship between the anti-seizure medication, epilepsy, and pregnancy. And we can see in pregnancy, the epilepsy breakthrough seizure usually happens due to altered pharmacokinetics, due to there is reduced neuronal excitability. That means a lower threshold for seizure in pregnancy. And this may happen due to hormonal variation in pregnancy, due to sleep deprivation, sleep alteration, because the mommy now has to wake up every hour to 2 hourly because of the fetal cake, because of the need for micturition. There is social stressor, and patients with epilepsy has been shown to have increased risk of maternal complication, and this includes cesarean delivery, preterm birth, bleeding complication, and so on and so forth. And obviously, with anti-epileptic medication, there is higher risk of congenital malformation, neonatal complication, and neurodevelopmental disorders, as we have discussed earlier. So given that the sole risk factor for breakthrough seizure is a reduced drug level, so how do we monitor drug level in pregnancy? As we discussed earlier, a decrease of more than 35%, which is 1/3 of serum level from baseline, would increase one's frequency for seizure. It is recommended to monitor drug level every 4 weekly throughout pregnancy, and obviously at the beginning once the patient is aware that she is pregnant. It is also crucial to monitor their drug level at 6-week postpartum visit and to titrate their medication if it has been titrated or escalated earlier on during pregnancy. Drug level should also be monitored when there is presence of seizure activity or even aura, and immediately if the patient experiences any symptom of toxicity. So as you can see from this table, the recommendation to perform therapeutic drug monitoring if the facility is available is actually to patients taking any form of anti-seizure medication. And you can see that most medication actually has a decreased serum level, and this include phenytoin, phenobarbital, and lamotrigine and levetiracetam and so on. So we are not just worried about breakthrough seizure. In pregnancy, we are specifically worried about SUDEP, sudden unexplained death of epilepsy. So although the occurrence is very rare, but because it involves maternal mortality, therefore it is extremely paramount to reduce this risk and to mitigate these risk factors as well. So this is the report of the registry on patients with SUDEP or maternal mortality happened secondary to SUDEP. And from the report so far, they've found 14 deaths in women with epilepsy. 79% are actually SUDEP, and this is actually a significant number. So what are the risk factors for SUDEP? It really depends on the type of seizure, because patients with generalized tonic-clonic seizures are significantly higher risk, and those who are not seizure-free are also at a very much increased risk of SUDEP. Mummies who has lack of nighttime supervision, those who are living alone, and not sharing bedroom with their partner or anyone else are also at higher risk. Those who are not seizure-free, those who are medically refractory, those with nocturnal seizures, and the list actually goes on. So these are the risk factors that we should try to manage in order to mitigate their risk of SUDEP. So I routinely prescribe precautionary advice, print it out and enclose it in the patient's antenatal card. So this patient can look back, refer back anytime, if they need to. And the precautionary advice would include avoid sleep deprivation, dehydration, physical and mental exhaustion. All these are stress factors that can trigger, or they are trigger factor for breakthrough seizure or SUDEP. Avoid sleeping alone, have shower instead of bath, do not lock the bathroom door, avoid operating machines or driving if they have not been seizure-free. Avoid swimming, do not cook over open flame without supervision, and do not climb to heights. So as a summary for antenatal care, it's important to continue the correct dose of folic acid to reduce the risk of neurotube defect to the offspring. And during booking, it's important to confirm the pregnancy and the localization of pregnancy, confirm the diagnosis of epilepsy, exclude the non-epileptic psychogenic disorder, repeat assessment if it's needed to confirm the status of epilepsy itself. Patients with nausea and vomiting in pregnancy or hyperemesis gravidarum should be admitted early for antiemetic so they can comply to their anti-seizure medication, and that would reduce risk of breakthrough seizure. Drug levels monitoring is advisable and strongly recommended if facility is available. We would offer fetal anatomy survey, which is a detailed scan at 20 to 22 weeks, and then fetal growth should be monitored, in third trimester because these patients are at higher risk of fetal growth restriction. Reduce all possible risk factors for SUDEP, provide the advice on precautionary measure to mitigate this risk. And last but not least, and of course the most important, would be multidisciplinary team care. Now let's move on to our third case. This is Madam Casey, who's at the moment 37 weeks pregnant, and she has now come to discuss about birth plans. She has generalized epilepsy with 2 episodes of seizure in pregnancy so far. She's taking lamotrigine and carbamazepine. So what are the key points in the management of intrapartum care? What are the key points of intrapartum care in patients with epilepsy in pregnancy? So we need to know the seizure frequency during childbirth. We need to discuss with the patient mode and timing of childbirth, discuss with them the pros and cons of vaginal birth versus C-section. It's important to continue anti-seizure medication. What are the risk-reducing measures to reduce their risk of breakthrough seizure or even status epilepticus? Provide adequate analgesia. What is the role of IV clobazam in intrapartum? What to do if the patient develops seizures in labor? How do we monitor the fetus? And shall we prescribe vitamin K to prevent hemorrhagic disease of newborn in their infant? So when it comes to childbirth, obviously we would want to decide on the mode and timing of childbirth. Once the patient comes close to term, so at around 34 to 36 weeks is the best time to discuss about this. But most of the time, mode and timing of delivery is dictated by obstetric indication, especially in patients with very good seizure control. Caesarean section does not reduce the risk of breakthrough seizure. However, adequate pain control and infection prevention will reduce the risk of breakthrough seizure. Many people speak about shortened second stage in order to reduce risk of breakthrough seizure or status epilepticus. Studies have now shown that there is quite limited role. It is not routinely recommended. We need to know there is risk involved in instrumental birth, trauma to the fetus, fetal injury, trauma to the mother, perineal injury, extended perineal tear, PPH, and so forth. And therefore, shortened second stage should only be performed if there is an obstetric indication. Seizure frequency. So breakthrough seizure is increased during intrapartum time, more so if there is inadequate pain control. Fortunately, most patients remain seizure-free, especially if they have very good seizure control. Triggering factors would include pain, anxiety, stress, dehydration, sleep deprivation, and infection. And therefore, if we can appropriately manage all these factors, then we would be able to reduce the risk of breakthrough seizures significantly intrapartum. So if a patient develops seizure in labor, what do we do? Do we give them magnesium sulfate or not? So remember, this is a patient with epilepsy and not eclampsia. Therefore, the choice of medication here is not magnesium sulfate, but rapid-acting benzodiazepine, such as lorazepam. This can be given IM. If you're giving intramuscularly, then it should be 4 milligrams. If you're giving intravenously, it would be 1 to 2 milligrams stat. And it's best to make available bedside when you have a patient with epilepsy in labor. The risk of status epilepticus is higher when seizure prolonged beyond 1 minute. And obviously, there are other options such as long-acting benzodiazepine, like the one that we discussed, clobazam. Clobazam has a role in patients with suboptimal seizure control antenatally, but we need to be aware of the risk of neonatal withdrawal syndrome. So if this is to be used, clobazam is to be used intrapartum, then we need to inform the neonatologist to be on standby during childbirth. What about pain relief? Is epidural safe? Yes. So neuraxial analgesia can be instituted, can be administered in patients with epilepsy. In fact, it is strongly recommended to do so in order to have adequate and effective pain relief to reduce their risk of breakthrough seizure. Pethidine, on the other hand, should be avoided because that lower their seizure threshold, that increase their risk of breakthrough seizure. Diamorphine can be used instead if the patient is not given epidural, and patient-controlled analgesia, PCA, can also be offered. Water birth is generally not recommended, especially in patients with poor seizure control because of risk of drowning. Finally, let's come to postpartum care. So essentially, postpartum care is pretty much similar in patients with those non-epileptic patients, except patients with epilepsy requires closer monitoring. Because there is always risk of breakthrough seizure in postpartum period due to sleep deprivation, stress from breastfeeding, stress from pain, be it post-C-section or post-vaginal birth. So these are the things that we need to take into consideration. And obviously, there is also risk of breakthrough seizure if the patient has got infection. So prompt and aggressive treatment of infection is the key to reduce their risk. We also need to remember to titrate their anti-seizure medication. So patients who has had their dose increased, especially those who are taking lamotrigine, if they have their dose increased antenatally, this should be revised within 10 days because there is higher risk of lamotrigine toxicity. But those who are taking other medication, which is metabolized by cytochrome P450 enzyme, can taper more slowly. So these are the patients who are taking carbamazepine, clobazam, phenobarbital, and their dose can be tapered, over about 4 to 6 weeks postpartum. Patients with epilepsy are also at significant increased risk of postpartum depression and anxiety. So do not forget to screen them for this condition because psychological psychiatric condition now has been identified as one of the most common cause, if not the most common cause of maternal mortality within 1 year postpartum. So what about patients who are breastfeeding? So generally, we still advise for breastfeeding. We need to understand the benefit of breast milk to the fetus. And not just remember the possible risk, possible drug effect leading to neonatal withdrawal syndrome. The drug level in breast milk varies, depends on the dosage of the medication and type of medication. However, the serum level in the neonate is actually very low. And based on current evidence, mothers should be informed that risk of adverse cognitive outcome is not increased in children exposed to anti-seizure medication through breast milk. So patients, babies who breastfeed from mothers taking sedating drugs such as phenobarbital, primidone, and benzodiazepine are at higher risk of neonatal withdrawal effect, and they should be monitored and be informed to the neonatal team as well. And for mothers who are breastfeeding, we would recommend a shift approach, although we understand the benefit of exclusive breastfeeding, but this may not be wise and may not be practical in patients with epilepsy, solely because sleep deprivation and stress can actually increase their risk of breakthrough seizure. Therefore, we should allow them to have uninterrupted rest, and shift approach would sound more realistic for these patients. Again, safety precaution advice to the care of the infant. Do not give a baby a bath without supervision. They should always have someone to assist them when they are bathing their newborn. Try to change and feed the baby on ground level. Avoid carrying the baby at heights. Do not co-sleep with the baby, and baby carriers are generally not advisable. Instead, they should be using a stroller. Finally comes to our last case that I would like to share. This is a patient, primate at 26 weeks gestation, brought in by ambulance, found to be unconscious with weakness, tonic-clonic seizure, which lasted for about 2 minutes, followed by post-ictal drowsiness. She's got no known medical illness prior to this. So although we've been speaking about epilepsy throughout the entire talk, we must remember in patients with no previous known epilepsy and now found to have new onset seizure, the guidelines say to treat this as eclampsia until definitive diagnosis is made. Therefore, in this sort of patient, this type of patient, the choice of medication is magnesium sulfate and not rapid-acting benzodiazepine. So we also need to take into consideration other pregnancy-associated conditions such as cerebral venous thrombosis, space-occupying lesion, reversible cerebral vasoconstriction syndrome, and so on. Not to forget our bread and butter, other conditions that can lead to seizure in any patient, such as infection, syncope, which can be associated with cardiac arrhythmia, aortic stenosis, carotid sinus sensitivity, vasovagal syncope, metabolic conditions such as hypoglycemia, hyponatremia, Addisonian crisis, and of course, non-epileptic attack disorder, which is a psychogenic problem. So in patients with new onset seizure, clinical history is paramount. We strongly recommend to perform an EEG because it's a non-invasive investigation. Look at their blood parameters to identify any risk of infection, any risk of metabolic disorder. We can always order an MRI, CT or CTV brain to exclude other conditions such as cerebral venous thrombosis or a space-occupying lesion. In patients that is now diagnosed with epilepsy in pregnancy, the first-line choice of medication is levetiracetam and not lamotrigine, purely because levetiracetam, we can achieve a therapeutic range very rapidly with levetiracetam compared to lamotrigine. And with lamotrigine, if we escalate the dose too quickly, we may, there is a risk of developing rash in the patient. And it's very difficult to achieve therapeutic range very quickly with lamotrigine as well. So these are my take-home messages. Most women with epilepsy maintain seizure-free during pregnancy, and pre-pregnancy seizure control is one of the most important predictor of seizure control during pregnancy. Non-adherence to anti-seizure medication and alteration of this medication clearance is the main cause of breakthrough seizure. Preconception counseling is paramount, and this should include choice of anti-seizure medication, optimization of the seizure control, and of course, once the patient is deemed safe and suitable to embark on pregnancy, they should be prescribed with folic acid supplementation at an appropriate dose. Antenatal care should also include treating nausea, vomiting, and hyperemesis promptly, monitor drug levels when facility is available, perform or refer for a detailed scan at 20 to 22 weeks, and obviously mitigate risk for SUDEP and breakthrough seizure. During intrapartum, time and mode of delivery really depends on obstetric indication, and it's important to continue anti-seizure medication during intrapartum. Avoid triggering factor considered long-acting benzodiazepine such as clobazam. But if you are using this, be aware of neonatal withdrawal syndrome and have neonatologists on standby. Rapid-acting benzodiazepine is to be used for patient with breakthrough seizure in labor. And this is IV or IM lorazepam. And we do not routinely recommend shortened second stage. In postpartum period, remember to titrate or de-escalate the anti-seizure medication if you have escalated it earlier in pregnancy. Encourage breastfeeding. Do not deny the mother of breastfeeding. That may actually trigger postpartum depression. Avoid sleep deprivation. Screen for postpartum depression and anxiety and psychosis. Last but not least, new onset seizure in pregnancy. Always think and treat as eclampsia and rule out all other possible causes, whether it's pregnancy or non-pregnancy related. With that, I thank you for your attention. Till we meet again.